colleagues. We will be discussing echocardiography, advanced techniques, and the implications for transcatheter treatment options. This is the appearance of a patient with advanced right-sided heart failure, and our goal should be to prevent that from happening. We should keep in mind that the clinical syndrome of right heart failure is due to right ventricular dysfunction and elevated right ventricular filling pressures. So we need a good understanding of right ventricular size and function. In addition, severe tricuspid regurgitation leads to further volume overload and worsening our right ventricular dilatation and dysfunction. So we need methods to better quantify regurgitant volume, regurgitant fraction, the degree of regurgitation. And our hope is by fixing tricuspid regurgitation earlier to improve RV function, decrease RV pressures, and lead to clinical improvement and better survival. Traditional 2D methods by transthoracic echo had their limitations, but now with 3D echo, we can actually better visualize the tricuspid valve leaflets and understand better the degree and the severity of regurgitation. In addition, transesophageal modalities help us as well have a better understanding of the tricuspid valve apparatus and the leaflets and the relation to the different structures neighboring them. Here from a transgastric view, we can understand better the different leaflets of the tricuspid. From an etiological standpoint, primary TR is less frequent, but occasionally we'll see a patient with Epstein's or a patient who we initially suspected of having a functional TR, but ended up having a significant septal flare leaflet. But most patients have secondary tricuspid regurgitation due to left-sided heart failure, right ventricular pressure or volume overload. And when we assess severity, we use various 2D methods that we know very well. But in addition, these days, we'd like to use vena contracta area of the regurgitant jet. And that seems to be a better measure of the true severity of tricuspid regurgitation. Rebecca Hahn and Jose Zamorano proposed an extension to the grading of the tricuspid regurgitation to include massive and torrential, incorporating measures from 3D vena contracta area to these measures. In addition, we know that for patients who have severe tricuspid regurgitation, part of it is because of severe annular dilatation, and that the tricuspid annulus becomes more planar. And as this happens, the coaptation decreases between the leaflets. There is further tenting of the leaflets towards the right ventricle, and that leads to worsening tricuspid regurgitation. It's very important to understand the size of the right ventricle, and we have 2D methods to do that, but more and more we rely on 3D methods that we will see shortly. We have many limitations with the 2D methods that we use. In addition, it's important to have assessment of the right ventricular function, and we have several methods that we use, from the traditional TAPSI method, which is an older method, to the S prime of the tricuspid annulus, to the newer modalities. And the newer modalities is essentially three-dimensional evaluation of the tricuspid and the right ventricle from a transthoracic approach. So what that essentially means is that by obtaining a 3D volume data set from a transthoracic approach, we can identify the right ventricle and we can measure it in a very accurate way. This is obviously requires dedicated multi-beat 3D acquisitions with a frame rate of at least 20-25 volumes per second. It gives us a unique measure of the right ventricle global size that includes the inflow, the outflow, and the apical regions of the right ventricle. It does not make any geometric assumptions. Whatever volume you have in your data set, that's what we measure. But it is dependent on image quality. We need a regular rhythm. We need some patient cooperation and some further training. Based on 3D volume data sets, we can measure right ventricular ejection fraction, and this has been shown to have correlation with the ejection fraction measured by magnetic resonance. Other measures that we can do are measuring right ventricular systolic strain by 2D speckle tracking, either of the free wall or free wall and septum. And that's an important measure of right ventricular function and can detect subclinical dysfunction earlier than we expect. In general, when we approach a patient when a patient comes to us for tricuspid transcatheter repair, there's a few things that we want to consider. One, transcatheter repair is mostly destined for patients who have functional TR with predominant angular dilatation. We need to have modest apical remodeling, not severe RV dilatation. We need to have some partial preservation of leaflet coaptation with normal tricuspid valve leaflet morphology and excursion. The right ventricle should not be massively dilated. The right ventricular systolic function should be preserved or only mildly affected. We shouldn't have severely increased pulmonary pressures, and we definitely need good imaging to approach these patients. So from a transthoracic approach, this is one patient who presented to us for evaluation, and we can see nice image of the tricuspid valve. This is a patient who had history of cleft repair of the tricuspid. She had primum AV canal defect as a kid, and she had complex repair. But this is a tricuspid valve. We can see it very nicely from a transthoracic approach, and we can measure the orifice of the valve as well. In addition to measuring TAPSE and STDI, we can also measure the right ventricular strain from the free wall and the global strain, as well as do 3D volumetrics of the right ventricle. And in this particular case, we see that we can get an end-diastolic volume of 180 mLs, injection fraction of the right ventricle of 52%, and some dimensions of the right ventricle at base and mid, and some further measurements. This is a very nice information. These volumes usually are an underestimate compared to MRI, but these are very good to have, and they're fairly reproducible if you have good imaging. Contrast this patient to this patient, who's again of similar age, but this patient has severe right ventricular dilatation, massive torrential tricuspid regurgitation, a very ill patient. The TAPSE and the STDI do not reflect significant systolic dysfunction in these. STDI is 9, the TAPSE is 16, the cutoff is 17, but still we know that this patient has a major problem with the right ventricle. Volumetrics tell us that the right ventricle measures 314 mLs in diastole, and the ejection fraction is about 36%, with the limitations of not having the best of images for this measurement. But definitely it's very useful measurements that we can definitely strive to have on all our patients. Looking at the tri-valve registry, we can see what is going on today in terms of transcatheter approaches to tricuspid regurgitation. And we have primarily MitraClip and other modalities less often. As a group, these patients are elderly. They have functional tricuspid regurgitation by default. And many of them have had previous left-sided heart surgery. NIHA functional class is advanced. Most of them had an admission for right ventricular failure. So these are patients who present late in the stage of right ventricular dysfunction. But we see that even these population of patients, if you get a reduction in tricuspid regurgitation, these patients tend to do better and tend to have an improvement in their NIHA functional class. Regarding the MitraClip that we saw very nicely before by Dr. Maizano, this is a very familiar device for the interventional cardiologists who use it in the mitral space. And this is a case that we used MitraClip on both the mitral for severe MR, and we implanted also 3 clips on the tricuspid in the same setting to decrease torrential tricuspid regurgitation. And we see here the deployment sequence, the fluoroscopics, and the final result with an vena contracta area of 0.59 for the residual tricuspid regurgitant orifice area. This technique has been validated initially by the presentation by Nickening of the first 64 patients. Pascal is another edge to spacer technique that also has had success in the tricuspid space, and we're anticipating further application. But we know that in order for edge-to-edge repair to work in the tricuspid space, we need to have a coaptation gap that's fairly limited, that we don't have big gaps. If the gap is more than 7.2 millimeters, then depending on where the location of the jet, success is not is maybe difficult. If the gap is smaller and the jet is mostly central or anteroseptal, then procedural success is highly likely. This is a patient who was referred for transcatheter repair, but the patient had a gap of about 1 centimeter, so she was rejected for tricuspid, and she went for TriClip. She was rejected for a TriClip. We shouldn't forget the coexistence of dilated annulus of the tricuspid valve in these patients. So other technologies like the cardioband aim to decrease the septolateral diameter of the tricuspid valve and with that ameliorate the degree of tricuspid regurgitation. But we do have tricuspid regurgitation grades that hover in the area of moderate to severe in many of these patients. However, this improvement, albeit modest, does tend to reflect in the patients how they feel, and it's important as a technique and a technology. Another technique which is very, it's a copy is the Bicuspid Ization technique, the K technique by the surgeons do, is a tri-line technique that decreases the posterior annulus, and the tri-cinch technique also attaches an anchor to the lateral wall, to the lateral annulus, and by pushing it, decreases the septolateral dimensions of the tricuspid annulus. Another technique that's fairly different is the implantation of caval valves in the upper and lower, superior and inferior vena cava, somewhat protecting the caval circulation from the torrential V waves of severe tricuspid regurgitation. There's also the forma spacer technique, where a spacer is implanted within the tricuspid annulus in order to provide a surface of coaptation for the tricuspid leaflets, and with that decreasing the degree of regurgitation. There are some data for 1 year results which are very promising, decreasing the degree of effective regurgitation orifice area, albeit most patients had torrential regurgitation. And that led to improvements in clinical symptoms. And there's some data also for long-term follow-up at 24 to 36 months showing some improvement, persistent improvement in the degree of tricuspid regurgitation and in terms of symptoms. In general, all the repair techniques leave some degree of residual tricuspid regurgitation. If you want to abolish tricuspid regurgitation, replacement would be the way to go, but we don't have much at this point. We have limited experience worldwide, a few cases done with the Navigate valve, but when the valve is implanted, patients are left with non-trivial or mild tricuspid regurgitation at most, and it's a fairly effective technique. We'll have to see where that goes. So in summary, novel echocardiographic techniques enhance our understanding of tricuspid valve pathology and the severity of regurgitation. We need better quantification methods for tricuspid regurgitation volume and fraction in order to more accurately document baseline and post-intervention changes in the degree of regurgitation. At this point, we rely heavily on the ERO method. 3D echo assessment of the right ventricle introduces a novel way to assess right ventricular size and function, and potentially has a role in monitoring of patients before and after interventions. And again, I need to echo the comment by Dr. Maizano that we need to intervene earlier and prevent irreversible RV dysfunction and failure in these patients. Thank you very much.
Thanks, Michael, for your excellent talk and complete coverage of a difficult issue. I don't know if the commentators would like to comment on the talk. Dr. Kounas, would you like to make a point on that?
Thank you very much. There's little to be said from a technical point of view, because obviously Dr. Chrissoheris and his team are more experts on the field. I just have to say that a lot of cardiologists have been trained over the past years in a way that we actually neglected the valve, the tricuspid valve. So it's up to us, people that are involved in echocardiography, to have a high suspicion of this clinical condition and refer to experts' cases that could be treated either through a transcatheter system or maybe surgically, as it will be shown in the next lectures. Obviously, we need data to make better decisions, because we need, for example, to know what's the surgical risk of a patient before we refer him. And it would be good to have maybe comparative data between patients that have been treated and patients that are on medical therapy, which are lacking. But that's why we have to move on with seminars like this to collect data and see what we can do. Thank you very much.
May I ask a question too?
Yes.
All right. I noticed that you try to help a lot the invasive cardiologists, giving them all kind of data when not to go for the valve, when not to go for the valve. And I'm wondering if there is any cutoff point you can stop us surgically, I mean, to go and put a ring there. When we get a patient with isolated dysfunction of the valve, of the tricuspid valve, we wonder if we are going to help this patient by putting a ring there when the function of the ventricle is borderline bad, close to the non-operable, I mean. We haven't gotten that much help from the echo people. They keep telling us about how bad the valve, the ventricle is. We want to know which patient to take in the operating room, where is the cutoff point, may not be a point, may be a zone, a gray zone. Can you define that zone for us when we should stop and not go for the valve? Because not only the patient doesn't come off the table sometimes, but doesn't do well in the future.
Yeah, I think if you have an estimate of right ventricular function, either by MRI or by 3D echocardiography, and if the estimate is that there is still some residual, like the first patient that I showed you that had an ejection fraction of the right ventricle about 50%, that's a patient that you could probably take to the OR. Whereas the second patient who has a very bad right ventricle, it would be a very poor candidate for surgery and a high risk for surgery as well. Again, we should not delay referring patients for surgery if we have the indications. But I think a key point of a key opportunity lies in the first. Many of these patients that I showed you in the TriValve registry had a previous surgical operation. And that's an opportunity not to be lost. If you have the patient on the table and you have moderate or dilatation of the annulus or even mild regurgitation, it's a good opportunity to intervene then before, because especially patients with rheumatic heart disease in the future will develop worsening tricuspid valve disease and RV failure. And we see that on and on. Many of our patients have had previous surgeries on the left side. But again, it's difficult to quantify and give you a measure. It has to do with multiple parameters, but I think the more we get into the details, rather than just eyeballing and say this is mild, this is moderate, this is severe RV dysfunction, but rather saying this is the ejection fraction is so-and-so, the strain rate of the right ventricular free wall is so-and-so, shouldn't go surgical, or we need more data based on actual numbers. That's what I'm
But if the question is, if there are cutoffs, there are no real cutoffs.
We need to get numbers that we can rely on if we want to
data.
be more objective.
Yeah, one short question.
Thank you.
If you have some myocardial reserve, of course you can intervene depending the tricuspid valve dimensions. This is a probable answer to Mr. Makos' question. Of course, you don't need a right ventricle which is fibrosed. You can see it from the TMR. You need, if there is some myocardial reserve, maybe the stress echo can help you.
You need to collect a lot of data. There's no straight cutoff.
Although we have to move on, I would like to ask, mildly depressed right ventricle,